Today, we are going to chat about patient experience, some goal planning and best practices, things that you can do to try to help engage your team and remember why we're doing all this stuff. We get so bogged down in our deliverables, our KPIs, our budgets, our FTEs, our schedules. That person who called out, again, the person on FMLA who we still have to figure out, find coverage for, and they're on FMLA and they should be back at work by now. It's so much that we need to be able to still remember, hey, why did we go to school? How many in here are radiology? How many are from our biomed side of the family? Fantastic. Radiology? Where were you the last hour? That one was set for you. Whatever.
Oh, well, I saw where you had them separated, imaging and biomed. We're all in one.
Yeah, I agree with all being in one. But so we are going to talk a bit about how we can find some best practices. A little bit about me. I have been in diagnostic imaging for almost 30 years. I remember my very first x-ray I ever took. It was a hand. They let me print it with obviously no HIPAA on it. I hung it on my mom's fridge. They put a sticker on it. I was so proud of that x-ray. It's the first one I ever did by myself. I remember the first time a portable printed. And I looked around for a tech to go with me because you can't go and do a portable by yourself as a student, realizing, oh, wait, I don't have to wait. I can go do this myself. I remember that feeling. I loved that feeling. I was specialized in pediatrics, specialized in trauma, ran trauma teams, the radiology department. I was that lead tech, department manager, the clinical instructor for multiple schools, ended up being a manager, a director, running 11 sites, working in the C-suite, doing everything from outpatient imaging to rural medicine to urban medicine, and I've loved every single second of my career. You could not pay me to be a nurse. Ew. I mean, come on, how hard is that really? What direction do you wipe? Back to front, front to back? How hard is that? They're not building hearts out of ones and zeros and making it beat in your hand. We get to do the cool stuff. I love what we do. I'm now an educator. I teach for Gurnick Academy. I've been an educator. I'm now the program director. I work with multiple facilities in multiple states, and I love what we do. And being able to take that passion for patient care that I have and driving it and finding a way to have that conversation in every single thing we do has been a huge passion of mine for quite some time. And maybe trying to remember some ways that we can help our techs who feel buried in the weeds, that patient care is everything. Taking a moment, finding a way, I think it's really important. And even if it's a matter of crossing the line and going, what we do, everybody affects it. Our biomed teams, they affect patient care. Front desk, they affect patient care. They are as intimately related to patient care as me looking at you going, hi, we're going to go ahead and take a chest x-ray. Can I have you go ahead and do me a favor and put this gown on open to the back? I'm going to have you stand against that wall for me. I'm going to have you take a deep breath. Do that one more time on that second one. I'm going to have you hold it. And between the two of us, we're going to get some really good images so that they can be read and that report can get to your provider. That simple moment of it's you and me toward a shared goal. It's not you versus me to get it done. And remembering that tiny little moment and that we get to be here, we get to do what we do. Sometimes it's hard to remind your techs that passion. Whether it's their first day or their 20th day or their 5th day working or 5th year working. Sometimes it's hard to remember that passion for what we do. So let's do a little, just had to play with it one more time. For those of y'all that missed it, my son gave me a brand new laser pointer and I'm going to use it. It's exciting. Alrighty. So this thing hated me the last time, so we're going to try it again. All right. So like any good educator, I got to start with conflicts and disclaimers. I have no conflicts of interest. I wrote it. Disclaimer, the views and opinions are mine. They are not anybody else's. They are picked up from quantitative and qualitative research and literature that I've gone through. And nothing I say represents the opinions, policies, or positions of the ASRT, the ARRT, the Board of Directors, AHRA, ICE, anybody else. It is my research. It is my passion for our field that drove the research in doing what we're talking about today. So we're going to talk about goal planning on consistent behaviors and patient experience. I'm not a big slide deck person. I was informed I needed to make one. So if I talk about things that have nothing to do with on that wall, you still get to get a copy of it. Think of it like a party gift. All right, so why does patient experience matter? Don't worry, I'll wait.
They're paying the
patients are why we're here.
True?
Actually, the entire existence of patients, this is what we work for. No patients, no us, right?
I always thought it was trampolines, but yeah.
Absolutely. So we work for them.
Yeah. Why else does patient experience matter? Now I want to be cold and heartless about it.
It improves outcomes.
Improves outcomes. Ha ha ha. You are my current favorite person in the room. That may change, but currently you are it. Why? Press Ganey, Sullivan Llewellyn, those words sound familiar to you? Reimbursement. We all know reimbursement is tied to patient experience scores, right? And Medicare and Medicaid pay based on your organization's patient experience scores because they are reported and they are the big gorillas in the room. Therefore, that private insurance company is not really going to pay that much more than they have to, or more than Medicare and Medicaid. So you could have Presbyterian Healthcare Insurance or Cigna Healthcare Insurance or insert organization here, healthcare insurance. They're not going to pay that much more than Medicare and Medicaid because they don't have to. Doesn't mean your premiums don't go up, but they don't have to. And because of that, patient experience matters, not just how we're caring for our patients, which is everything, obviously. It creates recidivism, makes them come back, right? How many times did, when you were a tech and you were working, someone came in and went, oh, I recognize you. You took care of me, my family, my friend, my cousin, my insert human here a year ago. And you watch them go, oh, I'm so happy you're here. Or did someone go, that when as a manager or as a leader, there was a tech, she had blonde hair and she had like blue highlights, or she was blonde, she was about that tall. She was fantastic. I really liked her. Think about engaging your modality leads to lead a huddle. Pick one day a week on Thursday. And it doesn't mean that you don't send them an email, here's the stuff you're going to say, but have them lead the huddle. It does a couple of things. A, it helps them to grow. And particularly if you have a leader who wants to grow into a management position, it's, it helps create the people behind you who are going to take over for you when you move on, right? It gives them ownership of what's happening in the department. They're no longer being talked at. They are part of the conversation. And that's a small change that you can make in the important, we're all doing huddles, so I don't need to explain to you what the importance of it is, but maybe think about who's leading the huddle. Doesn't mean you don't lead it one day a week, but look at your modalities. Pick someone from each modality to lead the huddle, or someone from the front desk to lead the huddle that day. It's 5 minutes. Send them an email what you want them to say. You're doing it anyway. Handoffs. How are we doing handoffs when it comes to not just the front desk to us, but my mammo patient is now your ultrasound patient. My mammo patient is now your MRI patient. Are they in the same building? Nurture, inform, communicate, and evaluate is how we can take care of a patient in real time, what we should be doing every patient, every time. Showing empathy, being focused on what they say, all the things that we know to do, right? It's just called the NICE model and doing it. giving clear explanations, not just, hey, we're going to go do a chest x-ray, let's go. Are you seeing that in your hallways? Let's hope not. But it wouldn't be a huge surprise if there are 50 patients deep, they're running behind, haven't had lunch, let's just go, let's just get this done, let's go grab that chest x-ray and do it. Keeping patients engaged and updated like we did a second ago. I'm going to come check on you. I know that you're doing this small bowel follow through and it's feeling like we're here all day, but I'm going to keep checking on you. Make sure that you're comfortable. Let's see what we can do to help you. And then continuous improvement. Talk to your patients. What do they need? And part of that can come from Maslow's hierarchy of need. So I'm about to tell you a story. It's a fantastic story. Come on in. No, come on. Whatever. Whatever. You don't get to hear my story. What you get for peeing. All right. So this fantastic, beautiful piece of machinery, this was my car. My father bought that car. It was not my car that I owned, but it was my responsibility to take care of this gorgeous, stunning Chevy Citation. Right? So we all remember Maslow's hierarchy of needs, Our patients are never going to come to us in their best day, right? No one goes to get an x-ray when they're running errands. I got to go to UPS and drop off my Amazon. I got to go to the grocery store. No, I don't. I'm going to have Instacart just deliver things. Instapeasant can bring me my groceries. And I have, errands to run. I'm going to go get Starbucks. Let's go get a chest x-ray. It doesn't work that way. Our patients come to us because there's something wrong. They're nervous. They're scared. They're concerned. They are never coming to us. Where's my laser pointer? This isn't what I want. Aha. They are never coming to us like this, are they? They're coming to us down here. Right? Well, there was a day when I was 18 years old, a brilliant young ingenue. How often do you get to use that word, right? And I was going to work at the mall because, back in the late 80s, that's where you worked. You worked at the mall. And it was my responsibility to take care of that car. So I looked at that car that morning. I got up early and it needed gas, but I was up early, feeling great. I had time to go get gas, go to McDonald's and get a Coke or a Dr. Pepper, and still make it to work on time. I was riding pretty high. Had a car, had a job, had a partner. Life was good. I was getting gas and I looked down and that tire, that one right there, that was the exact car, by the way. That was the day I bought the car, or we bought the car. He bought the car. Okay. That was the day that I took over taking care of that car. That tire looked really low. Well, I figured I should put air in it. As a young 18 ingenue, I knew nothing about PSI or that there's a little sticker that is inside the door that tells you what number you're looking for. I had time though. I wasn't going to be late for work, and I was living it up here. And I'm like, I'll put air in that tire. I put air in that tire until it looked full. Well, this was New Mexico in the high desert. In the high desert, it's very, very cold in the night and in the morning, and then it can get like 70, 80 degrees hotter by midday. I went to work at 8 a.m. I got out at 3 p.m. I walked out into the parking lot. I opened the mall door. I looked at this car in the parking lot and watched that tire explode. Not only did it explode, it took this entire front quarter panel, flung it all the way across the parking lot, and wrapped itself around a light pole. The front end of the car, I went from here to there in like less than a third of a second. I had to call my father. I had to go back inside the mall, grab the payphone. 80s people, there were no cell phones. I had to put a quarter in a payphone and call my dad and say, Dad, I blew up the car. Not the best day of my life. Still one of his favorite stories. I had to say phrases like, I tried to pull the quarter panel off the light pole and I'm not strong enough, because it went. So just as an example, we can very easily go top to bottom on a good day. Can you imagine where our patients are? And the minute that, oh, you're running behind 2 hours in the waiting room and no one has said a word to a single patient as to why you're running behind in your waiting room, they may have come in here, but they're really quickly sliding. Or your systems are down and we're going to have to reschedule you now. And my schedule's full and I can't get you back in for at least 4 days or 10 days or 14 days. We're going here to here. We need to understand that and remember that about our patients so that we're able to care for them. Some more ways that we can do that. Oh, wrong one. That one. End of visit summaries. So to be very cold-hearted, those breast gaining scores are important, right? We're getting tracked, we're getting monitored, we're getting talked to about them every month. How can you fix that score? Your patients are seeing you, and then they're getting an email or a letter in the mail for their breast gaining, right? If you were to take as a leader, whether it's you or one of your leads or one of your modality managers, grab 3 patients a day as they're walking out with 3 or 4 questions. How was your visit? Get to them now, in real time now, in person now, a human conversation now, and say, how was it? Did you feel like you got good communication from the front desk? How was it with your tech? Were you made comfortable during your exam? Did you understand what was happening to you? Or what the goals were that you had as a team to get that diagnostic study? Find 4 questions. Come up with a plan to get a key takeaways in real time. That's going to do 2 things. A, you are now in it together towards a shared goal of improving the department. They will respect the fact that you came out and asked them, or somebody did. And because of that, that could take a very negative experience and flip it to a positive survey because they've already feel like they were heard. And how much time do I have? Sweet. This is the fun stuff. All right. So those are some hints and tricks of things that you could do in real time, takeaway that you could take back. Let's think about the patient populations that you have. I want to talk about some differences that we have. Look around the room right now. Did we all grow up in the military in an Air Force family? Did we all grow up living all over the country, lived in New Mexico, family was from California, they were in the Bay Area, lived there every summer. You've worked in New Mexico and Texas, and you live in Vegas now. You're an educator. You work clinically to help. Is that everybody? Siberia. Look at Siberia. But my point is, look around the room. Take a second and ask the person next to you, where are you from? Cheating. We already know you're from Siberia. Tell each other where you're from. Go Buckeyes. Sorry. So are we from real diverse backgrounds? Right. Think about the providers and the techs in your departments and your facilities. Are they diverse as well? From all over the country or all over the world? Men, women, you name it, different cultures, different races. Well, that creates a diverse population that your patients need to be able to visualize and recognize and see in themselves their care providers. It makes a difference, the cultures that we care for and how we take care of them. How are we teaching our teams about diversity? We're going to put the political hat over there, the whole DEI thing. And it doesn't matter what your political leanings are. Today is not that day. So we can think about diversity, though, with what we do because of the fact that we still have to care for everybody who walks in our doors. We get to do that. We don't have to do that. We get to care for people. So how are we having the conversations with our teams carefully around diversity? Because we have to care for everyone. And in your areas, in your HR departments, are you recruiting from diverse backgrounds? Because it makes a difference if your patients can see themselves in their care provider. I had to get a little violent, sorry. I mean, generally right now, what we're looking at in all healthcare workers, we can see the ranges between just generically white, Black, Hispanic, Asian, and other. Whether it's aides of care workers, direct contact support, healthcare providers, 64% of all physicians right now are male, and the majority of NP, PT, and OT workers are female. Think about your patients. Are they able to recognize? Can I pick another one? Are they able to recognize themselves and the care providers in your areas? And if you look at the impact of that, racial and ethnic minorities are less likely to have a regular doctor and health insurance, depending on if they see themselves in their providers or not. This is a big deal. People just don't go to the doctors. And although I did not put slides in here for today's conversation, the LGBTQ plus community is the same way. There are so many who do not go get care because they don't see themselves or they don't feel like they can be honest about their care with the clinicians in the area that they're living in. It's very difficult. So don't confuse equity and equality though. I'm not saying don't hire the people who are the best at what they do. They still have to go to school. They still have to pass the same boards you do. They still have to know what they're doing. Obviously, don't hire around that rule, but embrace everyone who applies, because they could be the representation of a community that you're working in that is not seeing themselves. I'm hearing impaired. I have found that whenever I'm working somewhere, that is where the deaf community ends up figuring out there's someone there who can sign and communicate, and they go to that facility for their care because they know someone will be there to hear them, to understand them, just naturally, because there's someone on staff who's a sign language medical interpreter who can help with making sure that they're not feeling lost in their care. So we need to make sure that we are providing culturally competent care, understanding the differences in culture, and training around that. For example, in southern New Mexico, it's very much the Mescalero Indians, that is very much that community, or Apache. There are some real cultural rules when working with that patient population. Any woman who shows their first gray hair and on is grandmother or auntie, and you do not call them anything else. I may have never met you before, but you're a grandmother. It's a sign of respect. It is way more respectful than just saying Mrs. Whoever. It is, once you confirm that double patient identifier, it is, grandmother, may I take care of you today? You know that culturally there's about 1,000 safety pins holding that outfit together underneath that you got to look for. And more importantly, the young male children, a female cannot tell a male child what to do, ever, because it dampens the warrior spirit. So imagine trying to do a chest x-ray or a wrist exam on someone who's in pain, and I can't tell you what to do. And their mother cannot tell them what to do, because it will dampen the warrior spirit. You become very adept at creating buy-in for a study. We are working together to get this done. I'm not telling you what to do now. Now we got a plan. We're working together. But that is a cultural, you need to know the cultures of the communities that you work in. I've never worked in a culture or a community that is Amish. I don't know if anyone here has. Are there rules? Are there things that you just know to be true about an Amish community in terms of dressing or undressing a patient, or who is culturally best to care for a patient? Sure, I don't know.
They're not as, I don't think they're as strict as we probably think.
I just why I don't know.
The biggest.
Okay, it was very, very specific in the muscular. I mean, and think about the patients that you know you probably shouldn't be touching their hair. Don't go touching my hair. I spent a lot of money on my hair. Don't look like it. I know I've lost half my hair, but we think about the cultures that we treat, and it makes a huge difference if we understand that towards those patient care scores. All right, language. Of course, I'm going to put something in here about being hearing impaired and being different disabilities. Why? Because I can speak to it. Patients from non-English speaking backgrounds struggle to understand imaging instructions. I guarantee you, may I borrow you? You know things I don't know.
Okay.
Yeah.
Should I
Say, no, just say, I don't, Serbian, is Serbian the native language? I don't know.
Russian.
It is Russian. Okay, I see, I didn't even know that far. Say anything to me in Russian, anything.
А что ты хочешь, чтобы я спросила?
I'm going to assume she was saying, Dr. Walton, you are fantastic. I don't think that's what she was saying. But
What do you want me to ask you for?
no, but the point is, I've got no idea.
Of course.
Now I want you to say it slower and louder.
Что ты хочешь? Я тебя спросила. Still same.
I still got nothing. Do you? Did it help? Didn't help at all, did it? So think about that with the culture, the languages in your communities. Spanish is a big one. I grew up in New Mexico. I know 4 words. Respire, and I don't say them well. Respire, no respire, breathe, don't breathe. No se muevas, don't move. Dos margaritas, por favor. Those are my 4 phrases. And I said that last one right, didn't I? I got that one right, didn't I? The other one's kind of scary, but that one I got right, okay? No se muevas. I mean, it's not going to help if you don't speak Spanish, but same thing with if you're hearing impaired. If I can't hear you, I can't hear you. Saying it slower, saying it louder, right? We don't think about that. Little tiny things. So think about ways that we communicate. Are we all using cows even though we can't call them cows anymore? Wow, it's a cow. We all got them at the same time and we looked at that and went, cow, that's funny. That's what we're going to call it. Everybody does. Computers on wheels, that's what we have. Are you using interpreters that are medical interpreters? Video remote interpreters. Is it still super easy to get the front desk girl who speaks Spanish and have her come interpret for a patient? Well, it's not best practices, but is it still super easy to have them come help? Yeah, I was interpreting for the hearing impaired for medicine long before the cows existed. So I would get calls to go meet a patient at this hospital at this time because they came in through the ER, and they'd have to hold out care until I got there. Other than just keeping them, packing them on ice for a minute. But with hearing loss specifically, if you look, in 2019, there were 430 million people, 2030, 2040, 2050. Why are we having so many more people coming up with a hearing loss? What'd you say? Gunfire. Aging population. We live longer. We have all these medical advances that are keeping our asses alive a lot longer. And we got Instacart delivering groceries to my house. I don't even have to get in the car as a 90-year-old person to go drive to the grocery store to get my groceries. I've got Instapeasant to deliver things. Amazon delivers things. It's easier for me to live longer. Don't we live in a fantastic world? That's great. But we're also having an aging population of those age-related changes of hearing. So think about that. Turn the lights up a little bit. Make sure that your patient can see your face to read your lips. And what are they saying? What are the deaf and hard of hearing saying? 18.6% of surveyed participants report they do not get preferred or requested accommodations and interpreter for healthcare related appointments. 38.3% feel that healthcare providers treat them differently because they're deaf or blind. I can't tell you how many people assume I'm stupid. If I'm only signing to you and you can't hear and I can't hear you, and I'm only signing, or I take a lot of speech therapy to keep my voice. But if I get real tired and I get that behind my throat voice because I can't hear anything, the assumption is that I am an idiot. I have 7 degrees. I stopped being an idiot a long time ago. The providers believe that they do not understand or deliver culturally sensitive care, and 93.7% of survey participants feel that healthcare could do a better job meeting your needs. And that's not the biggest population in the world, for sure. But if it's happening to one culture, it's probably happening to a lot of others. I don't speak Spanish besides the 4 phrases I can spit out. So I can't understand my Spanish speaking patients, not really, or any other language other than sign or English. Am I making unconscious biases in what they understand? Maybe. All right, so provide interpreter services, understand cultural preferences, continuously educate our staff. Why do we care? Our ART standard of ethics that we all still have to maintain as techs. Number 3 says that the radiologic technologist delivers patient care and service unrestricted by the concerns of personal attributes or the nature of the disease or illness, and without discrimination on the basis of sex, race, creed, religion, or socioeconomic status. We are still responsible for these ART standard of ethics, even though it may have been more than 6 months since we took the boards. Y'all are still keeping up with your ART licenses, right? Okay, just checking. Don't make me have a moment. Alrighty, so biases. I am only going to read these notes because back to my kid, I have a 32-year-old son, beautiful daughter-in-law, grandbabies that'll make you cry. They're so cute. But when I reviewed this deck with my son, I read these notes to him. He goes, Mom, don't say it any differently. Read what you wrote. You wrote it right. So I'm going to follow his instructions and read. Don't tell him I did what he said, though. I'll never hear the end of it. All right. Unconscious bias is a hidden or unknown belief that we have about someone or something. We all do it. We may not be aware of it. It's part of our verbiage sometimes. We don't think we do, but we do. If you had a party to plan, would you pick Brittany or Mark? If you had some math that just wasn't mathin', would you choose Kai or Cindy? How did you make that choice? Do you look at a woman as being more loving and more nurturing, and a man as more protective and more able to change a light bulb? I don't know. I stopped reading it. But do we just unconsciously think that way? Is it a bad thing, or is it just a thing to be aware of? Same thing happens with social status, showing worth. Because you have a sports car, does that make you worth more than someone who is head of security for the Salvation Army and they love what they do? Does one person have more worth than the other? We know the answer is no, but are we unconsciously treating patients differently because of that? Language we use describing things or people show or give value or self-esteem. Are you sweet? Are you weird? Boys don't cry. I'm not your mother. Clean up after your own break room. It all sets up unconscious biases, some of the phrases that we make. To know whether you have a bias or not, and we don't think about it. There's this really great study that Harvard University did, an implicit association test. It's a tool to figure out whether you have not thought of hidden biases. These are all the areas that they kind of ask you some survey questions about and help you to self-reflect. It was pretty great research that they did in building that. And obviously you'll have access to the deck later that you can take a look at it. And microaggressions, they are subtle, often unintentional, discriminatory comments or actions. We don't think about it. It sometimes can just be part of the vernacular or slang of where we are in our communities. Assuming a person's preferred language. I assumed your preferred language was English only because that was the easier one for me to start with. I could have done this whole thing in sign language, but you all may have looked at me like I was crazy. Or Is that a microaggression because I assume you don't know sign language? Look at me, I'm a horrible person. Questioning a person's credentials based on their ethnicity and assuming my preferred pronouns. It's easy to assume that my preferred pronouns are she, her. I look much like a she, her. Mine actually happen to be she, they. I'm on the demi-boy edge of the gender fluid spectrum. But I don't necessarily, and I'm happy to explain that if you want to know what that means. I'm more masculine on the masculine side of being feminine. It's just who I am. I don't do, that's just me. So my preferred pronouns are she, they. Not necessarily she, her. I answer to her, but I kind of live somewhere on the edge of the middle. But it's easy to assume, right? We don't think about it. It's just easy. And I know we live in a weird world around pronouns and assumptions, but it can erode trust. If you have a patient who is, you assume one gender or another, and you only say one gender, and inside they're screaming inside, that's not me. Is it going to be easy for them to then open up and tell you their history and why they're there? No, because they already don't have trust. You didn't do it on purpose. You just did. It happened. So how do we talk about it? Instantly, we have to talk about it so that we can get that trust. And with our staff and our teams, it can create a hostile work environment. Are you sure of all of your staff's preferences of language, of communication? Do you have staff that don't like to be recognized? I had a mammo tech that for the life of me, she did not want to be acknowledged for anything. Not her birthday, not when she did something right, nothing. She wanted to come in, take care of her patients, and she was fantastic at what she did, but do not acknowledge me. It doesn't matter how fantastic her patient care scores came back and how, Jenny was the most amazing person. She made me feel so comfortable. She was great. I could never bring that up to her. I could walk by her in the hallway like this and not stop and go, Jenny, your patients are saying good things about you. Thank you. And never stop walking. Real quiet, real undertone, just for her. And I had techs who wanted and needed that. As we reviewed the patient care scores in the monthly meeting, all these patients said something about this person, and they're doing such a great job. I can see the work that's happening in the CT department. You guys are killing it. Your patients are talking about it. They're seeing it. I'm seeing it. You are being seen. The work you're doing is being seen. Thank you. Not by me, but by the people you care for. But if I did that with the mammo department, oh my God, it would have been the end of the whole damn world. They did not want to be acknowledged. Knowing your people, what do they need? Meeting them where they are. So how do we deal with those microaggressions quickly? Recognize them, train your staff, think about protocols and reporting. Make sure that reporting is something that's done in a positive way. We always talk about that, right? Reporting should be positive. So how do we impact a diverse culture? We want to make sure that we are improving patient trust and compliance. Oh, that's fantastic when that happens. Don't you love that? Communication addresses language barriers, health equity, reducing disparities in diagnosis, and making sure that's happening from the classroom into the clinic. So I always think as an educator about our students, you have clinical students in your sites. You are so darn lucky. You get to create and build the culture of the people coming into your department who are desperate to work there. And if you start it when they're a student in there as their clinical site, not only do you want to hire them because their job training is so much easier, right? They already know what to do. They've been doing it for you as a clinical student, but you are building the culture that your department's going to have in 2 years. It will take 2 years to change the culture of your organization from how your people take care of patients, every patient, every time, because you're starting at the clinical student and that folds over. All right, rounding, to double back on a couple quick takeaways. Are you rounding with your patients? That's kind of where that, not the NICE model, but the after visit summary comes from, is from rounding. Are you walking around or sitting in your lobbies? It's so hard to ask of that. I know, you're busy, so busy. Your schedules are insanity. But do you ever take 15 minutes and just take your badge off and go sit in the lobby and listen to the patients? Listen to the way they're calling patients. Listen to what the front desk is communicating with patients. Sit in the lobby and just listen. And then later, walk patients out. Be conscious of the wall and what the schedule is. Watch packs. I know you're doing it. And try to walk patients out. Try and identify needs. Try to get real-time feedback. It's really nice to be able to walk a patient out from MRI and have them be like, that was so great. That was such a great experience. And you go, thank you so much. Hold that door for them. I hope you have a great day. Really appreciate you letting us take care of you today. Let me know if you need anything. Here's my card. And then turn around and go right back to MRI. You know what? That patient you guys just had, they were saying the most fantastic things about you and your team. Makes all the difference, right? That instant feedback. And we talked about daily huddles. We talked about patient feedback, creating a culture of accountability. But do you role play with your students or with your clinicians? How are you practicing and training and doing annual training about how they're communicating with patients? I'm about as nerdy as it gets, and I'm super proud of that. I play D&D twice a week. If you look at me on a video chat behind my desk, you'll see all my D&D books. D&D is life. I have more dice than I know what to do with. So I decided that one of the ways, and since you'll have a copy of the slide deck, you'll have it too, is I made a couple of character sheets. One of an imaging clinician, Kim, and one is a patient's family member. You can use these in your next daily huddle, and it would go something very simple like this. You're a patient's family member, get a 20-sided dice. I have a geek over here. She'll let me play with her. If you curse my dice and it only rolls ones after this, I will blame you personally. I travel with dice. If I can't get people to communicate with me in meetings, I will make you roll for initiative, which means I'm going to make you roll a number, and then you're going to have to answer questions per number. Yes, I have a set of 7 metal dice right here because don't you travel with dice? See, some people get. Did you have your own D20 in your purse?
I have one upstairs.
See, we could smell each other out in the crowd. All right, so if you are the patient member's family and you are stressed out, and I'm going to ask you anything, you're going to bug me, be like, I want to go back. And you know that patient that you don't want to go back with you? You can feel the energy. You're like, yeah, you go ahead and wait right here and I'll bring her back to you when I'm done with the chest x-ray. No, I have to come back. I have to come back. Well, you want to convince someone to do that. Use this happy little sheet and you can roll charisma. Add a 15 to whatever you roll to tell me that's my number. You're going to convince me that you're going to be able to come back with me, and I don't want you to because I think you're going to be violent and aggressive and rude to me, and I don't want that in my life. So as the tech, I'm going to be like, yeah, no, I'm going to roll against you, and I'll roll a D20 as well, and I ended up adding 13, and depending on what's going on, are you trying, what am I immune to? I'm immune to being surprised as a tech. I've seen it all at this point, right? I can't be frightened anymore. I've watched you hurl into a bucket and thought to myself, you know what? Garlic Parmesan, that does sound good for dinner. Like you haven't done it. I'm immune to being exhausted because I see 75 patients every 8 hours, right? I'm flawless in starting my IVs. I have seen it all. I am great with patients. I can get a patient to do anything. These are my skills. These are the things I'm good at. But by the end of the day, I might get real worn down by patients constantly berating me and dropping my scores, dropping my health, making me more tired all day long. And here comes this patient or this patient's family members. They're also immune to being exhausted, but they're frightened and immune to being frightened because they've been there all day. At this point, they're irritated. They feel like they know everything. Let me see that x-ray. Or my brother's a nurse, or my sister's an x-ray tech, right? Let me take a look at my x-rays. And they're going to defend their family member to no end. So you could use this if you have role players to go, okay, I want you to roll against me and go, okay, well, I got a 35, and if you could beat that, then you'll be able to convince me to come back, and have them role play a conversation around a scenario. Where do you get your scenarios? You know those patient care surveys? You know, all that writing that they do. This happened to me, and they were like this, and then that happened to me. There's your scenario, and role play them through a scenario. What would you do? Here's some hints. You're trying to convince me to do something? Okay, well, roll for persuasion. You're trying to convince me to do that, and you're going to be aggressive with me? Okay, roll to hit. Did you say something offensive that would hurt my feelings enough to make me let you get away with whatever you want to get away with? So are we going to be able to track our patient experience? Track our scores? I love an analytic, and I love me a spreadsheet. So taking some of that patient feedback, we can then turn around and affect change. Are you tracking your patient experience scores now? How? Dashboards, right? Looking something like this, right? I had to wait until it was long enough for me to be allowed to use some of the data. So bear with the 2019, I had to wait until I was allowed to share it. But if you think about all these facilities, these are the December Press Ganey scores, overall clinic comparison, clinic to clinic, clinic ratings, facility ratings, because how they feel about the cleanliness of the waiting room is different than how they feel about how my people took care of them, right? So are you tracking them with dashboards and what your goals are and where you're actually sitting? And where do those analytics come from? Do they come from the Press Ganey website? Are you printing them off of there? Or do you have someone in your facilities taking care of it? So once you get those Press Ganey scores, you can track them. And here's just one location: monthly average score, how many responses, total mean, and then track it for yourself. Where are you? Are you looking at your scores? Are you tracking them for yourself? So that you can A, tell the C-suite, leave my people alone, they got this. It was 1 month blip, give it a minute, this is not a trend. And empower your teams. Look for daily improvements, engage patients, all these best practices that we know better, but get pushed slightly to the side because it's budget season, or COVID, or I'm short-staffed this week. And try to fix that cultural change around patient experience. Because if we communicate, we can have a velociraptor-free workplace. Helping your people understand the why these things are important will make it happen. You can't just go back and go, you need to go do this. If they don't get why, do your teams understand that reimbursement is based on patient experience? Financially, to keep the lights on, it affects that. If your people know that, it might make a difference. How often do you talk patient experience with your modality managers? With your departments? Outside of the monthly meeting where you have to review it, along with everything else, where it's just a byline in your staff meeting. How do you share data with them? Is it just verbally during that staff meeting? Do they see the numbers? Do you share the patient comments and go through, and do you keep their names or do you black out their names? Sharing those comments are very impactful. That's that qualitative data that is just so important.